Greetings, everyone. My name is Professor Julie Makani from Muhimbili University of Health and Allied Sciences in Tanzania, which also houses the Sickle in Africa Clinical Coordinating Center. I'll be speaking to you on behalf of colleagues in Tanzania, and I will briefly mention the experience from Sickle in Africa, which is a consortium that involves 8 countries in Africa. Just sharing the experience that we have with regards to models of healthcare in our countries. So Tanzania is a country in on the eastern coast of Africa. It has a population of 55 million people, and it's estimated that every year 11,000 children are born with sickle cell disease. Really, modeling estimates suggest that every year the number of children under the age of 5 with sickle cell disease who die is 15,000 or close to 15,000. What we did in Tanzania, and this is more close to 18 years ago in 2003, is that we decided to have an integrated approach to sickle cell disease. And in this instance, what we meant was that we wanted to integrate the improvement of healthcare services, research, and training into one comprehensive program. And we also wanted to improve awareness or advocacy, working with patients, patient communities, and other stakeholders to make sure that all these 5 areas, health, advocacy, research, and training, go together, 4 areas with coordination at the core of it. So in 2004, with funding that we were able to receive from the Wellcome Trust, we were able to start what we call the sickle cell study in the National Hospital in Dar es Salaam, Muhimbili National Hospital. At that time, there was already existing sickle cell clinics in pediatrics, and we were also seeing adults with sickle cell disease at the hematology clinic. So we estimated that we would have around 400 patients with sickle cell disease, including adults and children. Within a year, we had enrolled 1,000 patients, and we have been able to enroll we have been able to see over 8,000 individuals, 5,000 of them have sickle cell disease. One of the things about the healthcare for in Tanzania is that it's divided, as it is in many other countries, into 3 levels. And this is primary healthcare facilities, secondary healthcare, and tertiary healthcare. Muhimbili National Hospital is a tertiary healthcare facility. We also wanted to make sure that we included, particularly for individuals with sickle cell disease, home-based care, because we know that this is very important as sickle cell disease is a chronic disease. We worked with the Ministry of Health to integrate sickle cell disease into the strategy for non-communicable diseases in Tanzania, as well as the non-communicable disease strategy at the level of the African regional office in the WHO. And we're very pleased to share the news that in Tanzania, the NCD policy was launched in 2019. And in Africa, at WHO Afro in 2022, in August, the NCD strategy, particularly looking at integration of PEN Plus at first referral hospitals, is included. So when we talk about healthcare for sickle cell disease, we really are talking about current treatments that are available, and this is newborn screening or early diagnosis of sickle cell disease, provision of disease-modifying agents such as hydroxyurea, exchange blood transfusion, as well as top-up blood transfusion, and then curative treatment with allogeneic transplant. Future treatments or treatments that are currently under experiment research are ex vivo gene therapy, which is curative, and in vivo gene therapy. So our strategy is really to say that we need to look at healthcare as a continuum of healthcare and have a multifaceted approach to improving healthcare, from diagnosis, providing comprehensive care, counseling, access to disease-modifying medicines, gene and cell therapy, and really focusing on having a patient-centered approach. So with regards to comprehensive care, this is healthcare that we are strengthening at primary and secondary level, making sure that patients have sickle cell disease health passports where they can keep track of hydroxyurea use, the level of hemoglobin, if they have any complications. This is recorded in the health passport. We've also been optimizing standard of care by providing guidelines and training for healthcare providers so that they're able to increase the quality of care that they provide. Strengthening blood transfusion, making sure that there's prompt diagnosis and treatment of complications, particularly pain, as well as infections and severe anemia, and making sure that the patients have access to penicillin V prophylaxis, as well as malaria prophylaxis. In addition to that, we have been strengthening the referral system so that at primary and secondary healthcare facilities, they're able to identify complications of sickle cell disease and then refer them to the next level. So the next level is really talking about at tertiary level healthcare facilities, as well as some secondary level facilities where there's specialized healthcare for sickle cell disease. So improving access to hydroxyurea, making sure that patients have access for imaging. This is from CT scan, MRI, as well as TCD, and then access to not just top-up blood transfusion, but exchange blood transfusion. In addition to that, we have been working to make sure that individuals with sickle cell disease with complications, such as avascular necrosis of the hip, are able to be referred and are able to have access to hip replacement surgery. In terms of curative care, we've been working with 4 health facilities to strengthen their capacity and to establish bone marrow transplant in these 4 health facilities in Tanzania. They're spread out. 2 of them are in Dar es Salaam, and 2 of them are in are in regions. One in Mwanza, which has the highest prevalence of sickle cell disease in the country, and one in Dodoma, which is the capital of Tanzania. I want to say a few things about what we've been doing with gene therapy. We've been preparing patients to make sure that we're identifying patients who are would be eligible for both transplant and participating in gene therapy trials. We've also been improving patient access to what we call advanced therapy, and this includes exchange transfusion as well as bone marrow transplant. And then we've been preparing patients and the patient community and mobilizing resources so that we're able to offer individuals with sickle cell disease participation in gene therapy. In addition to that, we have been optimizing sickle cell services by improving and increasing the number of sickle cell clinics, improving laboratory services, blood transfusion services, and HLA typing and identifying patients who have matched sibling donors so that they can start, they can participate or they can receive hematopoietic stem cell transplant. In addition to that, we've been working to train personnel from the clinics, from the laboratory, from amongst the patients, so that they can be ready for and they are ready for advanced therapy participation. And then we've been conducting research at clinical level, looking to see what are the risk factors for clonal hematopoiesis, looking at the logistics of gene and cell processing, and working to get health facilities ready to participate in gene therapy trials. And this is important because we feel that having a multi-pronged approach would work. So we have colleagues working particularly closely with the Ministry of Health, and I'll talk about this a little bit later, working to strengthen and establish newborn screening and enrollment of patients into comprehensive care clinics, strengthening blood transfusion, as well as gene therapy. So this, by having gene therapy, by saying that we want to establish gene therapy and transplant therapy, we have seen that this automatically and also with intention improves services at secondary and primary level. So when you look at the geographical distribution of sickle cell disease in Tanzania, the areas that are dark red have the highest prevalence of sickle cell disease around Dar es Salaam and around the Lake region with Mwanza. And we have now, this is under the leadership of Professor Emmanuel Balandia and the team, they have been able to now identify Dar es Salaam, Pwani, Mwanza, and Zanzibar, and you can see them here, where their clinics, the sickle cell clinics are located in referral and district hospitals. So this is secondary and tertiary level health facilities, and patients are being enrolled on a weekly basis from Monday to Friday, depending on when the clinics are run. And patients receive SMS reminders 1 week and 1 day before clinic so that they can get a reminder to come to their clinics. I would like to share a little bit about our experience of sickle cell disease in Africa. And this really is a timeline that shows the discussion and the establishment of Sickle Charter in 2011. And then between 2017 up until 2026, Sickle in Africa, how we have reestablished Sickle Charter in 2020 with a focus on advanced therapy or curative therapy, and then Charter, which is an overall umbrella that coordinates not just sickle cell disease, but other conditions that we can leverage when it comes to improving care with sickle cell disease. So this is Sickle Charter, and we had colleagues from Ghana, Nigeria, Cameroon, DR Congo, and Tanzania. This is Sickle in Africa, that we're working in 8 countries. The clinical coordinating center is in Tanzania. The data coordinating center is in South Africa. In the first phase, we had countries, Ghana, Nigeria, and Tanzania, and they enrolled 13,000 individuals, both children and adults with sickle cell disease. And then in the second phase, we have additional countries, Mali, Uganda, Zambia, and Zimbabwe. Now, the numbers that we will enroll into the Sickle in Africa registry is 34,000 by the end of 2025-26. That sounds like a lot, but it's really a fraction of the number of individuals with sickle cell disease. We're only working in 7 out of the 54 African countries, and we're only reaching a fraction, 34,000 out of an estimated 3 to 5 million people with sickle cell disease in Africa. So we still have a lot to do. One of the exciting things that has happened, and this is work that was published by Ambrose Wonkam and his group, is when you look at the treatment centers in Africa, we have a lot of treatment centers, close to 10. And these are treatment centers that could be and are providing specialized services for sickle cell disease. We also have 3 countries that have already established transplant services, and this is South Africa and Nigeria, who have transplant services for sickle cell disease, and Tanzania that has recently introduced transplant services for hematological disorders in 2021, and we hope to provide hematopoietic stem cell transplant for sickle cell disease in 2022-2023. Sickle Charter, as a consortium, we started operationalizing it in 2020, and the focus of Sickle Charter under the leadership of Daima Bukini is really advanced therapy, which is exchange transfusion, transplantation, and gene therapy. A key component of Sickle Charter, and all these initiatives is coordination. We have, and we're participating as Tanzania in the newborn screening, the Consortium for Newborn Screening in Africa, which is an initiative from the American Society of Hematology. We're also participating in the NCD network, and we are establishing 10+ clinics, which consolidate non-communicable diseases, particularly sickle cell disease, type 1 diabetes, and rheumatic heart disease, particularly at primary level. And so CONSA and Sickle Charter are working at secondary and tertiary level, and 10+ and the NCD network are really working at primary health facility level. And then the Consortium of Health Advocacy Research and Training in Africa, Charter, is really looking at other initiatives, whether they're in blood transfusion, genomic research, HIV, that we can look, learn, and leverage so that we can improve sickle cell disease activities. There's been a recent initiative, collaboration between the NIH and the Gates Foundation to invest in gene-based therapy for sickle cell disease and HIV in Africa. And we're working with them as well as the Global Gene Therapy Initiative to see how we can strengthen and establish gene therapy for sickle cell disease in countries in Africa. All this, at the core of this, is or are the patient communities and the patients. And so one of the things that I was really excited about to hear last week during the Doris meeting was that the Consortium for Sickle Cell Disease Patient Communities in Africa has been established and it has been registered. They've got the leadership in place. And this is really critical because it allows coordination of the different patient-based and patient community organizations. Finally, it's really the importance of partnerships for sustainability, partnerships with government, health agencies, financing agencies, industry, philanthropy, and the community. If we all come together, this will really improve the healthcare that we're able to provide to sickle cell disease in our countries. Finally, it's really the issue of equity and time. Really like to remember Prof, Professor Kwaku Henifrempong, and all the individuals and people who have passed away from sickle cell disease in our countries and under our care. It's important that we think about equity when it comes to improving healthcare for sickle cell disease, and we also think about time. It's been over 100 years since sickle cell disease was described, and we now have a gene-based cure for sickle cell disease published in 2017 by Marina Kabatsana and her group. And so we need to think about how we can optimize care so that patients with sickle cell disease in countries in Africa are able to access them, as well as contribute to the evidence-based through research into gene therapy, as well as clinical trials for sickle cell disease. Thank you very much for listening, and I'm speaking on behalf of our funders, as well as thank you to our funders, as well as to patients and people who have been spending a lot of time working on sickle cell disease in Africa. Thank you very much for listening to me.